Hello, everybody. Sorry about the elevator music, but we just want to say a warm welcome to you on this West Coast day with lots of rain out there, but we look forward to a wonderful presentation. We know we have people from all over the province, and that just feels so good to know that we're reaching out and hopefully meeting the needs of British Columbians as you're doing your recovery oriented practice. So with that, a warm welcome to you. A little bit of background as usual. You know who we are. I think most of you are return people. So you'll see a picture of Jordan Clark, our tech support person, Dr. John Higginbottom, who's really, it's his idea that we're doing this whole advanced practice work. So we're very grateful to Dr. John Higginbottom and to Matthew, who is just our wonderful, long-suffering technical support person. So we just really appreciate him, and myself, Regina. So a warm welcome from all of us. You know that we're funded by the Ministry of Health and intend to provide leadership, education, guidance to the mental health field to help develop and put effective evidence-based psychosocial rehabilitation practices into place. That's our hope. And you'll know that we're very grateful to our instructors for their support and expertise. You'll know that many people do this work. This is our 21st presentation, and people have been doing this on their own time, and we're very grateful because we could not do this work without their support. And please, if you have a moment, do have a review of some of our archived and high quality evidence-based sessions. So we're hopeful that they are useful. We learned that people from all over the world are beginning to access them, from Korea and Australia and all over the place. So that feels really good as well. So purpose, I think you know this, transferring evidence-based knowledge, clinician consultation, providing training and education events, developing web resources, and supporting the Provincial Advisory Committee and the Committee for PSR Practice. All that to say is that we hope that we are a support to your practice, that we provide information that's useful, timely, and evidence-based. Just so you know that we are in the process of developing a new series around employment. Please look for that in January. So a new series of 6 webinars focused on employment. We've heard the feedback from previous sessions, and so we're happy to learn that some things we're doing well, and we will also include additional information. We'd heard that people wanted to learn more about providing employment services for youth and substance use, so we are going to do our very best to include that next time. And also we're in the process of developing a series of 6 sessions around core competency for psychosocial rehabilitation. And so this is really a pre-pilot adventure for us. And so we are going to be developing that in January as well. So please look forward to some of those offerings as well. Always, we really rely on your feedback, because it's only with your feedback that we can do a better job. So we're very appreciative to each of you who've provided feedback after each and every session, and we look forward to more. So that's how we learn and how we do a better job. So we really appreciate your feedback. Thank you. And now it is my great pleasure to introduce you to Angela Louie, who has worked in mental health field for over 25 years in acute care, day program, and community mental health settings. Angela is currently the coordinator of Rehabilitation and Recovery in Fraser Health, Mental Health and Substance Use. And over the past 8 years, many of you will know that she has championed the recovery-centered clinical system within Fraser Health and has supported its implementation within tertiary services and the housing program. She has developed and delivered recovery workshops for staff at Fraser Health, Vancouver Coastal Health, Island Health, Provincial Health, Interior Health, and community agencies. So you'll know that we really have an expert with us this morning. And of note, Angela is also a silver medalist in the 2005 World Championships of Public Speaking. So with all that, I just hand you over to Angela with a big thank you to her for giving. There, am I on now?
Your voice is on, just start your webcam.
Okay. Oh, start my webcam. Start my webcam. There we go. Okay. And start sharing. Okay. Great to have all this technical support. Hello, everybody. It's great to be here with you and to share some of the experiences that we've had in Fraser Health.
in terms of implementing a recovery approach. So I'm going to share the specific model that we're using in Fraser Health and tertiary and housing. But, I think you will be able to see the applicability with just recovery approaches in general. And as I go through, it will be helpful for you to type in your questions. Matt's going to, sort of collect them and pose them from time to time, because I think sometimes I don't give as much detail as sometimes people want to hear. So if you've got questions about specific things, I'll do my best to answer those questions. Okay, so let me get started. So, one thing that I think when you're implementing any approach or any program, you come across this whole attitude about, we've heard about this recovery, it's jargon, it's the buzz term, it's just a passing fad. And recovery has been around for decades now. So you wouldn't think that people would think it's just a passing fad, but often, from my experience, staff are undergoing so many changes in their workplace that everything feels as though it's just something that's going to be the flavor of the month. So, I think when we're introducing something like recovery, which might go against the grain for many programs, I think a lot of people feel like, okay, if I just ride this change out, it'll go back to the way it was before. So one of the things I'm going to say quite a lot probably in this hour is that the infrastructure that you create is going to be essential. If you don't create any infrastructure, then it will be just a passing fad. So the question that we had when we started this is, how do we implement something across programs? It's fine, like I work in recovery programs, and it's fine and dandy to implement a recovery approach for, rehabilitation professionals or people that work in rehabilitation programs. They're already doing this work. But how do we go beyond rehabilitation staff and really bring something that's going to stick? That's really what our challenge was. Yeah, we can do something, to start with, but how do we actually make some long-term changes? So I'm going to start with my first introduction to this particular picture, the recovery-centered clinical system. And that was in 2005. I went to an IAPSRS conference, and I can't even remember what that stands for anymore, but it's the International Association of Psychosocial Rehab. And this was in the States. And I went to a session put on by the Telecare Corporation, and they were talking about this particular model. And what they shared was, they were delivering mental health services, and they were experiencing a lot of difficulties in their service. Staff injury, violence, those sorts of things. And they wanted to decrease it. And so they revamped their whole way of doing business. And they went back to the literature and they searched out what's the best thing to do. And they read a lot of recovery literature. And so they actually turned their service upside down. This is what they came up with. So I'll just describe it a little bit for you. So this really has three different aspects. In the center, it's the recovery journey. So it's about the person's own experience of their life. That is really what we're concerned about. So everything we do is about facilitating that person's experience of their own life. And how do we help them to live their life the way they want? So that's the main concern. The big circle with all those words like power, non-judgment, individual uniqueness, motivation and respect and dignity, that's about the recovery culture or the relational, interactive environment that the person is in. So whether it's your inpatient unit or it's your Clubhouse program or it's your housing program, residential program. So whatever that relational environment is, that in fact is the biggest intervention that we have, how we shape that environment, what we do to contribute to that environment, so it facilitates a person living the life that they want. Then the little circles on the outside, those are the recovery conversations. So if you are concerned about how do we help a person live the life they want, it probably involves having certain conversations, certain topic areas become important, like how do you make choices? How do you figure out who you are? What's your identity? How do you connect with other people? How do you connect with, the universe beyond you? How do you awaken your own sense of hope? How do you reduce the harm in your life? So these are just topic areas for conversation. Well, when I heard the description and their experiences in this seminar in 2005, I got really excited because, as you probably know, recovery concepts are very abstract. They're esoteric, and sometimes they don't come with practical, hands-on kind of tools. So this was one way I thought it really packaged concepts together in, I thought, an easy to understand way. And it came with some tools and workbooks that made it more concrete. So I really got excited about this. And I brought back my excitement to my workplace, and I shared it with the leaders that I was involved with. And some of them heard me put it on their desk, and there it sat for a year. And another leader I spoke to really took it up. So sometimes it's finding the right ear to share your ideas with that really made a difference. So luckily for me, I did have an ear of a rehab coordinator who presented it to his boss. And this was somebody with an open mind. And at the time, in 2005, Fraser Health was undergoing the Riverview redevelopment projects. Some of you probably remember all of that time. And I thought, this recovery picture really would go well in a community mental health setting. I thought, this is where it ought to go. But our director had a different idea, because what opportunity opened up was this Riverview redevelopment. And he said, it would go really well there. And I thought, really, that's not what I would have expected. But as it turns out, it was a really good opportunity. And over the next year, we made presentations to the design committee. They sent a number of people down to investigate what it was actually like on the ground in Oregon, and to investigate the thinking and the work behind this model. And it took 2 years before the tertiary committee actually adopted this model as their clinical model. So in Fraser Health tertiary adult settings, the RCC is adopted formally as the clinical model, which is a big deal because it will drive other things. And it wasn't until 2009 that we had our first staff training. So if any of you are implementing any new ideas, I think sometimes just be aware that it does take time for ideas to sink in and to be bought into from upper leadership. It took us 4 years before something got started. So our pilot site was a tertiary site that was already in existence, Connolly and Cottonwood. And we were lucky that we had a manager that was really on board. And so because it was the clinical model for tertiary, the steering committee was developed. There was, a wide representation from management, coordinators, the tech support from our electronic documentation system. So lots of people were involved. And we developed, at that time, a 4-day staff training. And we developed a lot of infrastructure processes that went along with this, frontline staff support, and a physician workshop. So I was seconded to be a dedicated person to lead this project, which is probably unusual. But there were some open doors at the time. just want to say something. Well, I'll move on. So this is what I see as what we did. We formed a steering committee, and the steering committee really led some different avenues. So one being the training, the guidelines, practice support, and evaluation. So that's what our steering committee did. So for the training, because I was seconded, I had the opportunity to develop the training and to deliver it. And we had a 4-day training. We put all the staff, it was mandatory. So you can imagine a 24/7 tertiary site, mandatory training for all staff. That was a huge undertaking. So we, I think, went through 4 rotations of the training so that everybody could go through. So that's a lot, that's a big financial commitment for an organization. So this slide is just a snapshot of what it is now. It's evolved into a 3-day training, and this is what I include in the 3-day training. So just some ideas about what recovery is, some general concepts, and then we go through specifically the 3 components of that model. So the recovery journey, what that is, the recovery culture and the experience of what that means, and then recovery conversations. Because, you know, I think for staff on the ground, it's easy to, you know, recovery concepts aren't rocket science, but you really have to understand it at a deeper level, a more, you know, a heart level or an intuitive level to really work with it. So that's what my intent was for building this training, that it wasn't just a head exercise, it needed to be a heart exercise as well. So at the same time as I developed the staff training, I kind of knew that physicians would have a difficult time accessing a 3-day training. So we actually invited Mark Raggans. Some of you might have heard of Mark Raggans. He's a psychiatrist down in the village. And we invited him to come and do a 1-day workshop with physicians. And that was a really great thing, because although he said a lot of the same things, he was a physician. So I think physicians can relate to other physicians. They do similar work, like psychiatrists do similar work. And after that workshop, one of the psychiatrists came up to me and said, you know, this is stuff that we already know. We've heard about this. But honestly, if a physician doesn't tell us, we don't listen. So I thought that was interesting, and I knew that. So it was really great that we were able to invite a physician to relate to other physicians. That was a great thing. And then we developed a whole set of evaluation tools. And at this time, you know, this was 5-6 years ago, we went with a lot of the tools that Telecare had already developed. Because we were using the model, we wanted to use those tools. So that's what we developed. And at the time, they had tools that they don't have them on the website anymore. But my recovery, my strengths were self-rating scales, harm in my life, client engagement. So we use those so that the program could take sort of a pre and sort of annual snapshot. And we're still reviewing evaluation tools now, but this is a snapshot of what we used at the time. This is called My Strengths, and it's just a self-rating scale. It's not the most visually easy tool to use, very wordy, but it was, you know, one of the best things that we had at the time, because we could get a sense of just where somebody was at. You know, they could sort of rate how they felt themselves. So that's what we started with. The other thing that we wanted to do was to provide some practice support for the clinicians and the staff on the ground. So I was seconded for about 18 months. So I was available to help, you know, any staff who had questions, or just to provide some hand-holding or anything that staff needed. So that was really a luxury that we don't have so much anymore. But at the time, I think it really fed into people feeling supported. So that's how we started. And then the guidelines. So this is what I mean by infrastructure, that not only do we need to have training, but you need to have a documentation process that supports a recovery approach. You need to have policies in place that support a recovery approach, that sort of thing. And what we ended up developing as a committee, this is probably hard to read, but something called, we call them swim lanes. And this is like the process of what happens when somebody comes into tertiary until they're discharged from tertiary. So from the resident's point of view, from each of the clinical role point of view. So this is an old one. It's been updated. It doesn't have a family role, which it does now. But it tells you, okay, so what happens when somebody is admitted into tertiary? What does the resident do? You know, they're getting settled. Maybe some of the staff are completing some of the forms or some interviews. They're having conversations. What happens within 4 to 6 weeks of admission? So some of the conversations that happen about recovery start happening. So this gives a guideline to the staff in terms of process. This is part of the infrastructure of what needs to happen. So I think if you are implementing something, this is a great little tool. It's just a visual, it's called Visio, but you can make it from any program, I guess. It gives everybody an idea of what's expected. So, where are we at? Okay. So, once we did the pilot at Connolly Cottonwood Cypress, that was the first pilot site. Then different tertiary units came on board, and it's all across the continuum from the the least supported to the most supported to the most secured. So Connolly Cottonwood Cypress, and then Memorial Cottage in Langley, and then Cedar Ridge in Chilliwack, which is a locked unit, Timber Creek, which includes a secured unit as well as an acute unit, an ICU unit. So lots of different tertiary units. And so over those 2 years, they were developed, and we did offer the training to all their staff. And then we kind of fell off the table a little bit because there wasn't an infrastructure for how this was going to continue past the initial training. There wasn't any committee process or any planning process where all the sites got together in terms of the recovery approach. So each site ended up doing their own thing, interpreting things in their own way, and not really having on-site support other than their own managers. And I think, they did their best to support their staff, but it ended up that each site, just developed their own way of doing things. So for a couple of years, people were left on their own at each site. And it was only a couple of years ago that we picked up again. So that was a big challenge for us. How do we sustain the initial energy and intent of implementing a recovery approach? And if you don't have, this kind of infrastructure, a channel to work with all of your sites, how do you communicate? How do you continue to plan? Then each site or each program is going to have its own interpretation, and it will eventually devolve, I think. So for us, in 2013, we got the go-ahead, the authority to form a committee. So that included all of our tertiary sites. All of our tertiary sites had a coordinator that was involved in the committee. We had a physician. We have a family member, a person with lived experience. So this committee is now about how do we have some consistency across all the sites. And our first order of business was just to talk about what is everybody doing? How are we seeing this? What's our first order of business? So we thought what we would do is an evaluation across all the sites. Where are we at after this training that's happened 2 and 3 years and 4 years ago? So we used the recovery-centered measure, which was developed by Telecare after we started. So this was a couple of years after we started. And I did include that in your package, so you'll be able to see that. And it was, luckily for us, something that Telecare also researched. So they validated that particular tool. So it was great. It went along with the model, and it was a research tool. So we did that with all the sites. And we also did some staff interviews because we wanted to kind of drill down a little bit and find out where is everybody at, because it's been a few years. Not everybody's on the same page. And so we got a lot of rich information from those. And so we're still in the process of kind of looking at those findings and figuring out where we're at. The other, sorry. Okay. Okay. Let me just. Okay. Is that good?
So folks, just if you are listening at an appropriate level, you just want to turn down now.
Okay. So I'll be screaming at some of you and talking at a good level for some of you. So we're finally, after 8 years, we're getting together with all the tertiary units, and we're working on a standard or consistent recovery plan document. And this is a long time coming because everybody's developed their own thing. So it's, if you think this is kind of a passing fad, the overnight success takes years. Okay. Okay, so maybe I'll stop there. And if there are any questions, because I didn't talk a whole lot about, the culture and stuff like that. So if you have questions about culture, or I'd love to answer anything at this point for tertiary. So while we're getting the questions, I will say that during the training, because it was a Riverview redevelopment project, many of the staff came from Riverview, not all of them, but many of them. A lot of them were on board already with this whole approach, and they were inspired and kind of relieved that we're going in this direction. Finally, the upper leadership and management are saying, yes, we should work this way. I've done this for years. So that was really refreshing. And not all staff, though. There are a number of staff who don't work in this way. And even if they were, through the training and sat through it, really, they didn't change their practice. So we had a whole range of staff buy-in.
A couple questions there. The first question is from Anne, who asks, what was your change management model? And then you'll see that Jenny's got a question as well.
Okay, change management model. So I don't know. So basically, what we did was it was to provide some training to the staff. That was kind of the initial part of the change, and our intention was to provide support on the ground to continue the practice change. And that lasted for 18 months while we were able to do that. And because there was only one pilot site in the beginning, so for the first 18 months, it was easy for the staff to get together and to share experiences and to support them. Once I wasn't available for that, and once everybody was kind of on their own, the practice support on an ongoing basis was really non-existent. So kind of the change process halted at that point, I would say. We had no plan. That's not unusual, right? That's why things seem like a flavor of the month, because okay.
Jenny's question there. We would like to hear about your experience in the culture shift and what support was provided to staff who were making that shift.
Yeah. So, sorry, what was the first one? Hear experience on the culture shift. So, the first pilot site, which was Conley Cottonwood, we had a manager there, Judith McCrae, who was just really inspirational. Like, her management style was to be, very present. She lived and breathed the recovery approach. She lived and breathed having a relational approach, and that relationships were the beginning of everything. So because she was such a strong influence and a model, I think this is one of the most important things. Leaders on the ground are a model. She was a model. So I think in that case, the staff really saw how it would play out. They experienced it from their leader. They had a little bit of coaching from their own leader. That really made a difference. Where we didn't, I wasn't involved so much after in all the different other settings. So I don't know, but I do know that the leader has probably the most impact out of anything that you can do. If they live and breathe it, that is what will make the most difference. If they don't live and breathe it, that makes the most difference too.
Right. Sharon's question there.
With multiple sites and based on your experience, I got to put on my glasses now. Okay. How hard to really get everyone following protocols? What consequences? Okay. Well, that's more, how do you make sure people follow protocols? Well, it's the same with any administrative process. Whatever process you have for staff to follow any protocol is the same as you would use for this. So if you have an infrastructure that says, a plan is going to be developed within the first month, then whether it's recovery plan or any other care plan, it's the same administrative expectations. So that's what I mean by building it into the infrastructure. If you have an expectation that you have a client review every 6 months, it's the same expectation. So it's administrative. One more question before we move on?
Sure.
Is there an example of the new client self-evaluation format? Okay, so what we've started to use just this couple of years is the recovery-centered measure. So this is something that you will have for reference. And there's 3 parts to it. One is a client evaluation, I guess, of the culture. So from the client's point of view, are the staff actually facilitating their feeling of hope? Are they treating them like a unique individual? Do they do these things? So from the client's point of view, also there's one from the staff perspective. Do staff actually do this from their own perspective? Third part of it is the staff perspective of the staff culture. Do other staff create a climate for me to feel hope? Do they inspire me to, work in a way that gives me the most choice? So the culture is not just the client staff culture, it's the staff to staff culture too. It's all in one because we all experience the culture. So I hope that gets to some of that. I'm going to move on to the next program that we worked in, and that is with the residential facilities. So these are the 24-hour licensed facilities, or boarding homes, they used to be called. And in Fraser, I think there are 37 of them across Fraser. So this was not something that was led by me, but it was led by the manager of the housing program. And I was involved along with other people on the committee. And it really started with the manager saying, it would be great if we had a consistent care plan for all residential facilities. And I think at the time, he was probably thinking of a nursing care plan, consistent nursing care plan. But because there were a number of us who were really recovery minded on the committee, it ended up being, we really ought to put in a lot of recovery language and a recovery approach to this plan. And it became a recovery plan. And this was a phased implementation over 4 years. So it was a lot of talking about how do we develop this plan and then how do we implement it in the homes. So you can see some of the locations on the map where the houses are, where the facilities are across the region. So it was challenging in housing because 37 different facilities means almost 37 different owners or operators with different ideas of how plan is delivered. So that was one challenge. And the other thing is that because they're licensed, we have to work within the licensing environment, because licensing really carries the bigger stick for facilities. So we had to synthesize our mental health requirements, recovery language, and also licensing requirements. That was a huge task, while still using first-person language, recovery approach, which means involving the person in their own planning, and a collaborative approach. That was a huge challenge, and especially for some facilities who may not think in that way. I think a lot of facilities at that time were still delivering a directive kind of care plan. The staff would plan, and the residents might sign off on it or something like that. But a lot of the impetus for the plans came from staff. So that was a huge culture shift. So what we ended up doing, we developed an initial draft of the plan. I didn't include that, but it was because I'm an occupational therapist, I kind of came in with my occupational therapy lens and developed a plan that I thought worked for me. And we rolled it out to our initial pilot sites. We had a 1-day workshop for the managers of care and 3 hours on site at each facility, each pilot facility for the staff. And the reason why we did that instead of what we did for tertiary, a 3 or 4 day workshop, is because they didn't have that muscle. They couldn't, they were only funded to have a certain number of staff, and they couldn't just bring everybody off the site into a 3-day workshop. So we tried to accommodate their budget. And the facilities came back to us and said, well, this is all fine that you've developed this recovery plan, but really my staff don't know how to do this. Like, how do we get from 0 to recovery plan? Care plan, we know how to do that. We know that this and this and this and this are needed. But how do we actually work with somebody to develop this blank page, basically? So that's when we kind of went back to the drawing board and developed the information gathering tool. I think I included that in your reference. And it's a huge document, but it really is meant to be a conversation guide. It was us trying to say, this is how you talk to people. These are some topics that you can talk about. It wasn't meant to be a, question for question interview, but just some prompts and some guides for staff to say, yeah, why don't you talk to somebody about who's important in their life? And it doesn't have to be a sit-down interview, when you're going out for a walk, when you're going to the grocery store with a resident, when you're making dinner, you can say, what did you used to enjoy when you were younger? And conversations can spring from that. That was our idea. And in fact, the facility things we did, they found that the most useful. They told us that, I found out things that I never knew about this person. They've been in the facility for 10 years, and we never talked about this. Because I think sometimes when you're doing your work on the ground day to day, you kind of get into a routine of what you talk about. And I think that's what a lot of staff felt, like they have a routine of what they do, what they talk about, and they don't necessarily touch on just conversations that you might have with a person. So that's what the information gathering tool was meant to do. And from that, then there might be areas that the person identifies, I'd like to get back into taking playing my trumpet a bit more, or yeah, I haven't talked to my sister in a long time. I really miss her. So some of those conversations were the springboard of what would populate, or what would get talked about for the recovery plan. That's how it would work. So for the housing program, the housing manager started a steering committee right away. That's what we were. And again, we touched on each of these four things: what was going to be the training, the guidelines, the practice support, the evaluation. So I told you what we did for training and guidelines. This came from the housing program. So basically, as we piloted the document, we would take feedback from those pilot sites, and we revise the document, both for the ease of use and for the information. The whole idea was that it would be one plan. We wanted one plan for the resident. So the idea wasn't to have a recovery plan over here and a nursing care plan over here and a Cardex over there, because that actually led to a lower quality of care. You have all of these different plans. So one plan for everything. That was a real challenge. So this is what I've included in your document is our latest version of the plan. So this is after 4 revisions, 4 phases of rolling this out. My idea initially was really just this part, which was totally client-driven. Everything comes from the client. That's all we need. But of course, that doesn't fly when you're looking at licensing requirements as well. So this is the client-driven part. We really wanted to keep this up front based on the client's hopes and dreams. That's the first part that gets looked at. The second part is the licensing requirements and other areas like that. So safety and harm, there's dental, there's oral care, there's nutrition, and all those licensing requirements that need to be there, that staff need to do. So how this works is that there may be some things that are client-driven. Some clients, because they've never even been asked this, they don't even think about what do they want. But hopefully over time, they will start to take some ownership of their own life. But even with licensing requirements, even if there are things that staff are obligated to do, they should always be in conversation with the person. The person should always be involved in being aware of what this is, and as much as possible, being involved in developing that part of the plan as well. So it's both, the licensing requirements are both client-driven and staff-driven. And so I'll just leave that at that. Okay. Oh, I was going to say that in terms of the practice support, what we ended up doing is enlisting the help of the occupational therapists that we had in the communities, because they have been champions of recovery for years, as well as the mental health CRP staff, so the case managers that are involved in supporting the facilities. So those 2 mental health staff really were the leads in supporting the facility staff. That's kind of how it rolled out. So some of our communities don't have occupational therapists. They only have case managers, so there was a little bit less support. Those communities that had occupational therapists had both of that support. Okay. And in fact, what we're doing with the housing programs, we are just starting, again, a phased evaluation approach. We're piloting a part of the recovery-centered measure with some facilities, the client portion and the staff perspective of client service. So we're just taking a little snapshot, seeing how it rolls out, and hopefully we'll be able to do more with that part of the evaluation. So in terms of housing, I think housing has moved a lot faster than tertiary because there was a coordinated regional approach to this. That really made a difference. So how do we implement across more programs, and how do we make it stick? So I would say the four things, maybe I should stop before I go on here and see if there are any questions specifically about housing. I know that there are a few of you who are part of the Fraser residential program. And
maybe
great.
Sharon's question about how much actual time now have to give.
How much actual time do managers have? I'm not sure if you mean the managers of the facilities or Fraser Health managers. Managers of facilities, so the managers of care, are really on site quite a lot. So it probably depends on the size of the facility and also their personal style. Some managers are very hands-on, so they're there with their staff a lot, and maybe some are not so hands-on. So it kind of depends.
No fidelity gap.
No. Probably the same for managers in Fraser Health. You know, it kind of depends on their own style and personal energy. Has this model been used in other areas, addictions? So I would say that in our substance use services, they're much farther ahead in terms of a recovery approach. You know, they never started with a medical model. They started with a grassroots recovery model, you know, 12-step and all of that. So I think they're farther ahead in terms of having a person-centered approach, farther than us. But what we're finding now, we're working quite closely with our practice leader in addictions. And in fact, he does a lot of speaking with mental health staff. So there's a lot of crossover with motivational dialogue. Some of our residential program staff have now, you know, had some exposure to motivational dialogue with Mark. So we're really trying to share our language and share the concepts because we're all moving in the same direction. That's what we're hoping, this sort of confluence of ideas. Has the model been used? Oh, Gisela, okay. Yes, for clubhouses. So we're going to get to that as an example, because Gisela heads up the Clubhouse program, and I think you know she and Anthony have been able to do a lot in such a much shorter time frame than 8 years. So let me move on to that then. Okay, so so just to sum up what I think the essential elements of the support are the top leadership needs to be on board, program leadership, the infrastructure, and the direct clinical support. Those are 4 areas that I think are essential that you need to have. So in terms of top leadership support, oops, I don't have anything there. So for me, that's like management and directors. So people who actually, write things down in documents that endorse something being a clinical model. People who have the political will to set aside financial resources to something. So top leadership support is very important because if you don't have the political will behind you and somebody's saying, yeah, this is a priority, make sure you put aside resources to it, then it can really fall off the table fast because there are so many competing priorities. So we're lucky because we have an infrastructure that's regional that we can actually have consistent leadership support throughout our region. So that's essential. Program leadership support. So this is, I would say this is like the managers of our tertiary programs or the manager of our housing program or the manager of care in the residential program, coordinators of the program. that's what I would say is the program leadership level. So people who are on the ground giving leadership support to staff. I would say this is without this, you will get nowhere. If your program coordinator is not on board or don't see this as a priority, it is not going to get done. And if they don't model the kind of approach that you want to demonstrate, then it's not going to happen either. So, because I've seen program leaders change, and like almost overnight, the program culture changes. It's amazing. Cultures change, very much influenced by the on the ground leader. So, you might not have any influence on who the program leader is, but if you do, if you are in the hiring process or you get a chance to influence their training, that is really essential that they're on board. The infrastructure support are things like, for us, how does this get input into the electronic documentation system? What are staff expected to document? How often are they expected to have client reviews? Do the documents that they're filling out, are they person-centered? Are they using recovery language, or is it using more of a staff-driven language? So all that kind of infrastructure. Do the policies support a recovery approach? That kind of infrastructure, in the end, will sort of make or break something being sustainable. And the direct clinical support. So how do staff actually get support on the ground, hand-holding and sharing experience on an ongoing basis? This has been a challenge for us. How do we continue to give staff the support they need? We're exploring different things like ongoing refresher trainings. We tried to do like a webinar. We weren't too great at that. So these are different things that need to be considered. So Gisela is my counterpart in Fraser, and she leads up our Clubhouse program. And I think all of these different types of support she has actually taken advantage of. So top leadership support for Clubhouse, we have strong manager leadership across all 12 clubhouses. So we have a consistent top leadership that has given clear vision, clear targets for their clubhouses. And so the on-the-ground leaders, the clubhouse managers, really were able to get on board and to help develop the infrastructure. So Gisela's led the infrastructure support in developing forms, documents, clubhouse profile, guidelines, so that infrastructure is set. And she's also helped coordinate the collegial support. So every year, all the clubhouses get together and have a learning exchange. They have quarterly meetings where they exchange ideas and get on the same page. And they've been able to do this in like 3 years. It's been very quick because the conduits are already there. So, when you have all of the different supports lined up, it can go very fast. So this is a little snapshot of what they're using in terms of a recovery plan. Very simple, and it's meant to be not so clinical. So it's not about goals, because goals can be scary. It's really about, okay, you're here at a clubhouse. What do you want to do? Is there something you want to focus on? And then what are some things you might do? Some possible steps. So it's much more open, it's less pressured, and it's more about having the person think about what they want and the clubhouse staff being a support on that journey. So it's not an A to B to C necessarily. And the other piece of their plan is a wheel. So this is even less goal directed. It's more of a self-reflection of where you are in your life, different aspects of your life, and using that as a dialogue for what do I want to do now? Is there something that I want to strengthen or put my energy into? So those are a couple of ways that Clubhouse programs have helped to talk to people about their journey, their recovery journey. So it's very exciting. We're all starting to go in the same direction. So for us in Fraser, where to next? Well, so our next step, our housing manager is now saying, okay, we've started this process with licensed facilities. Now we want to go on to non-licensed facilities. That's another huge, piece of work. And Fraser Health is also starting a community redesign process. So we're taking a look at our especially longer term teams and saying, okay, what is really the best way to deliver service for these people? And so we have an opportunity to think of, to really think outside the box. And of course, recovery thinking is going to be a big part of that. And we haven't really started thinking about inpatient units yet, but that is another piece of our continuum that I think we'd love to have some influence in. So the question I'm going to leave you with is, are you considering implementing a recovery approach in your programs? And you might be doing it already or really successful. What elements of support do you think you need to develop? So I'm going to leave it there and hopefully take some questions.
Thank you. Amazing. Yes, we've had some questions come in, and I'll just offer to folks that this is a great opportunity to approach somebody who's done it and done it incredibly well. Work through the kinks the first time around, and any questions that you have. The first question that I know we've got from a little bit earlier, I'm just going to grab is what role and where do peer support workers fit into this process?
Okay, so peer support workers. So we have peer support workers in each of our communities. Well, I should say peer support workers embody a recovery approach. I mean, they live it. They're an example of it. And so, although we probably don't have as much, we definitely don't have as much peer support service as we need. We have little bits in every community. So every community has peer support workers available to them for individual and group kind of interactions. And we have peer support workers in the community mental health centers. We have them in tertiary, most tertiary, and inpatient units now. So we've kind of got them in those areas of the continuum, and some residential facilities. They'll have some presence. So we definitely need a lot more. One thing that we've, I think a couple of other ways that we've used people with lived experience to help our system is to include them a lot more in different committees that we have. So, some of the committees, our steering committees, have people with lived experience and family members. And also our community redesign process also has representation. And I think it really makes the thinking richer, from a planning perspective. And we've also started to expand our delivery of the Wellness Recovery Action Plan. We've had, kind of a minimal amount of RAP workshops offered, and we've expanded our capacity using clinical staff as well as peer RAP facilitators. And I think that is really also going to help shift our culture, because it provides an opportunity for staff to develop their own RAP plan, and for us to realize, we're all just people. We all have, our challenges. And in delivering RAP, whether you're a clinician or a peer, it breaks down that barrier between us and them. We are all human beings dealing with challenges. So we definitely need more peer support workers in our system, no doubt.
Great, thank you. A question there from Jenny. Can you give examples of program leader modeling in a residential facility?
program leader modeling in a residential facility. Well, the one of the first, I'll just say, give an example. One of our first pilot sites was a facility for younger adults, and the manager of care, she was just really on board, and she told me a story. She said, before we started all this, she said, a young person would come into their facility and, he said, oh, I'm coming into this facility. This is where people come to die. And she said she was just, just heartbroken that this young person would think that way of, of a facility, but that's maybe the idea that people have, that once you're in a facility, you're there for life. And she said, she actually took the initiative to have all of her staff trained. We went through a 3-day training for all of her staff. And she really started to work with her staff and thinking, okay, how do we do this? One of the things, they did an activity, it was a hopes and dreams collage. And they did this with their residents. And she said, people started saying, I'm here to recover. She started hearing that language from the residents. And, they posted their collages on the wall. And you could see that it wasn't about, sort of clinical things like about symptoms or, the fact that they have psychosis or anything like that. It was, I'm a brother. And, this is a poem that I wrote for my family. And, they had pictures of fast cars. And they had pictures of, a trip to Hawaii. Things like that, that anybody would have about their life. And it was, she just took the initiative to start those activities. She encouraged her staff to have those conversations. She encouraged her staff to work in this way. She talked to the residents, she had conversations, hard conversations. A lot of her residents had issues with substance use. They self-harm. They left the facility for days at a time. And so a lot of the conversations were hard with residents, and they were just real. It wasn't that she wasn't being honest or, she just gave platitudes. There were just real honest conversations about what people are dealing with. So.
I think one last question about the data that's gathered through surveys, through the recovery plans, and the staff and individual self-assessments. What is done with that data? What does it inform?
So we've really only gone through one round of using the recovery-centered measure with tertiary and the staff interviews. So when we did the recovery-centered measure, we have a certain amount of data because it's numerical data. But we felt, because we were hearing different things, especially from the coordinators about what was happening on the ground, we thought, well, this doesn't give us enough sort of rich information about what's really happening. What are staff really feeling? So that's why we decided to do some targeted staff interviews as well, just to hear from people themselves what things were going well and what were the challenges. So, we've just taken that data, we've presented it to the Tertiary Steering Committee, which is the upper leadership of the tertiary programs, managers and directors and physician leads. And so we kind of gave them some high-level, high-level information and some recommendations. So that's kind of where it's at right now. And there, we're going to be continuing to discuss with them, where do we go from here? So from those recommendations, from the information, what does the steering committee feel as though the next step would be? What could they support? What could they endorse? Because any recommendation or step does come with resource allocation, whether it's the time of the staff or whether it's financial resources. So, they have to think carefully about what they could actually support. So that's where we're at with that process.
Coming in from Barb. Do you ever get feedback from the people for whom the system has been developed?
So, part of the recovery-centered measure is a client survey. So for tertiary, in fact, we had probably a better return from the clients than we did from staff because the clients, we were able to support the clients in filling out the survey. So we had peers available for the residents if they wanted help. But actually, a lot of the residents, if not all of the residents, in some cases, filled out the client survey. So this is an example of the client version of the survey. So this is really about, it speaks to the culture, because the culture is an intervention in and of itself. So we want to really get a handle on, are we creating the culture that we're hoping to create? Are the staff really interacting in a way that facilitates these things? So things like staff members make me feel more effective in my life. They work in partnership with me. They work with me without judging me. They don't really listen to me. So some of these are worded in a positive or negative way to try and get away from just a positive bias. Staff members make judgmental statements about clients. So that from a client point of view, we're hoping that they're going to be honest. And by having peers who are not, working with them day to day, we're hoping that, they feel safe enough to answer. These are all anonymous. So this gives you an idea. So the staff version is the same questions, but just worded from the staff point of view. And I think Matt is getting that one. So the staff version says things like, okay, so this is the staff-to-staff version. So this is about what's the culture like between me and my colleagues. So things like staff expresses disapproval of choices I make. So if I'm working with a colleague, do my other colleagues, sort of express judgment or disapproval about what I do? My colleagues make me feel effective in my work. My colleagues work together without judging each other. My colleagues don't really listen to me. My colleagues make me feel less powerful. My colleagues accept me for who I am. So this is about the staff interactions. And, because this recovery model is about the culture, if the staff feel, judged, it shows. The culture doesn't stop with the staff-to-staff interactions. If I feel like I'm being judged all the time, or if I feel like I'm not being valued, not only do I feel it, the residents feel it too. So it's, it needs to go in all ways. If the manager is part of that culture, it gets felt by everybody. So the staff-to-client relationship is important, and also the staff-to-staff relationship is important. So that's why there are 3 versions of this survey.
Okay, well, I think, unless there are any other questions, I think we may wrap up. Just wanted to give a huge round of applause and largest thanks to Angela for your incredible work. I think there was just a wealth of information there that people can take back, and not only in practice, in theory, but in practice, in application, apply to their own work. So thank you so much.
Great.
You folks are inspired now.
Good. Yeah, and if anybody wants to get in touch with me, I'd be thrilled.
And how would they go about doing that?
Can my email be made available?
You can,
okay,
if you're comfortable with that.
Yeah, that's good.
Best thing.
The work email.
Yeah.
Okay.
So just as Matt is doing that, I want to add my thanks, and Matt has clarified that those tools are available on our website. My understanding is that some have a cost attached to it at this point, but
no.
Okay, Angela says no.
No.
Actually,
on one of the slides I have the Telecare website, telecarecorp.com, or .com, yes. And they have all of their current materials available. So they have workbooks, they have the recovery centered measure, just information about their model, and you can download them for free. They just like you to leave your name so that they know who's using them. And I think probably the research paper that they use to validate their tool is there as well. I mean, we've been lucky to, have a great relationship. They've been more than generous offering their consultation with us, but they've been very generous.
And I've got that link there now, as well as your email. Lots of positive feedback coming in. And so we'll say thank you and sign off for today, but just a reminder that our next session is going to be taking place on November 27th via the Advanced Practice website, and another webinar with the Mental Health Commission of Canada, launching and discussing their brand new recovery guidelines. So this is the don't miss session. There are few, but very few seats left, so I encourage you to go onto the website, psyrehab.ca/workshops, in order to register for that. And following, we've got upwards of sort of 8 to 10 sessions in plan for the next coming 6 to 8 months. So lots of great new learning opportunities and interactive components coming. So we look forward to talking to you then. Take care, everyone.
Bye-bye. Thanks so much.